Well, welcome to this Scotland-Malawi Partnership Health Forum. A few technical housekeeping notes to begin with. Craig has hopefully managed to mute and to offer support, as Gemma has, on muting the microphone. As you see, it's at the bottom left-hand corner of the toolbar, and the mute needs a red strike through it diagonally. If you can hear me okay, please would you type OK or some other creative word using the chat function, which is in the toolbar at the bottom, third from the right, or give a thumbs up or applause. I think you can even do, I'm told, using reaction keys, which are also in the toolbar if you click participants. Oh no, I think that's only raising a, oh no, that's raising a hand. So reactions, you can see I'm a beginner at this. Reactions is in the right hand side of the toolbars. So either a thumbs up or some clapping hands there. So there are quite a few people adding to the chat to say that they can hear. That's great. Hopefully the technical support contacts that were shown on the opening slide there will enable those experiencing technical difficulties to get some assistance. As well as there being this live participation now, a recording will be made available from tomorrow with a link from the SNP's website, and we'll signpost on our social media platforms to that too. If you don't wish your voice to be part of the recording, please just let the SNP know today. And where presenters use any slides today, we'll also share these afterwards. My name's Stuart Brown. I'm the Deputy Chief Executive of the Scotland-Malawi Partnership, and I'll be facilitating today's meeting. As is obvious, as I've mentioned, I'm no expert on Zoom, so do please bear with us. My colleagues Craig and Gemma are doing the Zoom hosting and technical support from our respective homes scattered around, and our Chief Executive David will provide a roundup of key points and next steps at the end of this meeting. Whether you're a regular participant to the Scotland-Malawi Partnership's activities, as I know that many of you are, or if this is your first SNP event, you're equally and warmly welcome. This health forum brings together those in Scotland involved with health links with Malawi, Scottish Government funded and not, to share insights, lessons learned, and to identify tangible actions to enhance the work of practitioners between the two nations. It is, as many of you know, an informal group and without any sort of pecking order. As ever, there will be time for questions, comment and discussion. If you're thinking of asking a question but not sure, please do. It will likely benefit some or all of the forum, and there's no such thing as a stupid question. I'd ask that we all keep these quite brief, please, to enable as many people as possible to be heard. Please use the chat function, again at the bottom of the toolbar, to lodge interest in asking a question or making a comment, and we'll come to as many of these as we can in the Q&A sections. There are two main parts to today's meeting. Firstly, we'll have a presentation from Professor James Garden of Edinburgh Surgery Online at the University of Edinburgh about their online master's programme and the particular success they've experienced and skills retention that this has helped foster in Malawi. We'll then have some time for Q&A. The second section, which we aim to come to around 3:30 UK time, 4:30 Malawi time, possibly slightly earlier. This part on COVID-19 preparedness in Malawi. We hope to hear what the situation is in Malawi, what Scotland and Malawi partners can do to support one another, to hear the perspective of donors, and to share what we can do as individuals, organisations and networks. So let's begin, and it's a pleasure to invite Professor James Garden to share the experience of Edinburgh Surgery Online with us. James.
Thank you very much, Stuart. I hope everybody can hear me. I am obviously delighted to be able to participate in this online session. Online surgical training is something that with which we are very familiar. Stuart, can I just ask, can everyone see my screen without any difficulty?
I can see you very clearly, James. You've not shared screen as far as I can see yet.
Rightio, let me just try that then and see if I can. How about that?
Yeah.
Great, thanks, yeah.
Perfect, good,
Yeah.
all right. I obviously want to share my experience with you of how we have been involved in Malawi. And obviously I have to give a little bit of background before I come on to the specifics of our activities there. I've got the usual disclaimers. Actually, firstly, I have to confess I was born in Carluke, Lanarkshire, so I was only a few miles down the road from the birthplace of one David Livingstone. And I've been trained as a specialist liver surgeon with time in Edinburgh, Glasgow and Paris, but I have been gainfully employed by the University of Edinburgh since 1988. And I'm also going to confess that I'm a fellow of the College of Surgeons of Edinburgh, because you'll begin to understand that the collaboration between the university and the College of Surgeons has been key to our online education activities. And the confession that I also have to make is that although we have been in Malawi for some 10 years or so with our online education programs, I actually only traveled for the first time to Malawi in October of last year as part of a capacity building weekend retreat. And I did very much enjoy my short travels there. This is about our global education activities, and obviously the University of Edinburgh has been into global education for a long time. Medicine's been taught at the University of Edinburgh since the beginning of the 16th century. We have a College of Surgeons, we have a College of Physicians in Edinburgh. The university itself was modelled on the University of Bologna, and medical teaching on the universities of Padua and Leiden. That was partly because founders of the medical school here in Edinburgh undertook their own training there, and often that was where the wealthier Scots would go for treatment. Medicine was big in Edinburgh in the 18th, 19th centuries, and at any one time there were something like about 1,000 students studying medicine in the city. But the medical school at the university was not actually founded until 1726. I'm just going to give you a very brief history here to underline the relationship that there was between the College of Surgeons and the University of Edinburgh. John Monro was president of the College of Surgeons, and he clearly believed in nepotism because he organized for his son, Alexander Monro, to be the founding professor of anatomy when the medical school was founded in 1726. And indeed, this generation of Monros, Alexander Monro, primus, secundus, and tertius, ruled the medical school by occupying the chair of anatomy at university for some 126 years. I just want to highlight Alexander Monro because you'll see he was an apprentice to his father. He actually helped his father at the Battle of Sheriff Muir at the age of 18, so he served his apprenticeship. But he was an enlightened individual, studying his anatomy in London, his surgery and midwifery in Paris, medicine in Leiden with Boerhaave, and became a fellow of the College of Surgeons in Edinburgh in 1719, and not long after that became its main teacher of anatomy, and then, as I've indicated, the foundation professor of anatomy at the University of Edinburgh. He was an Enlightenment figure, and the key to his enlightenment was that he decided to lecture in English rather than in Latin. And that was one of the reasons why those interested in pursuing medicine would come to Edinburgh, because many of its competitor academic institutions were still teaching in other languages. And of course, the Edinburgh Medical School was part of an Enlightenment which was responsible for founding of various schools and universities globally, 5 of the 7 Ivy League medical schools in North America, but founding medical schools in Australasia, Canada, and even London. Now, that global delivery of medical education continues to the current day. And what I want to focus on now is why our online education programs have become so strong, and why it is that although these were designed originally to support training surgeons in the United Kingdom, they have become very successful internationally. I'm not going to give you a lecture on how we go about training a surgeon, but I think it's important to understand that training a surgeon is not just about the surgeon acquiring technical skills and being proficient at undertaking surgery in the operating room. Clearly, they have to have a basic surgical knowledge. They have to know how to apply that knowledge. Traditionally, that is acquired in the workplace, or it's self-directed, and the clinical skills associated with that are learnt in the pre-operative and post-operative setting. And there are also non-technical skills, which we now know are as important as the technical skills that the surgeon is responsible for. But clearly, self-directed learning, has its limitations. Working or gaining that experience in the workplace may be quite variable. And so it was with that in mind that way back in 2006, just after the College of Surgeons, just after the College of Surgeons celebrated its 500th anniversary, the college and the University of Edinburgh got together to sign a memorandum of understanding to collaborate. Some in Edinburgh might only recognise the College of Surgeons as a bus stop, Surgeons' Hall, but that institution is responsible, along with the other colleges of surgeon in Great Britain and Ireland, for the professional development of surgical training. They're responsible for setting the standards, the curricula that are required, and also the professional examinations that allow these individuals to become a member and later on a fellow of the College of Surgeons. The University of Edinburgh is all about producing medical graduates, but can also support the academic development of medical graduates and surgical graduates in particular. Now, again, I'm not going to give you a long diatribe about the basics of surgical training, but essentially, when graduates come out of medical school, they embark upon 2 years of so-called foundation training, which are about their acquiring generic skills, before moving into an early years surgical training program. And once they have successfully negotiated their professional exam, they'll go on to a period of specialist training before they go on to become a consultant surgeon. When we set up our online education programs, there had been a reduction in the work experience of trainees because of European working time legislation. I've already hinted to you that the fact that the professional examinations, although having a set curriculum, the study for the professional exam was often unsupported. It was left to the individual to make sure that they had covered the curriculum, and if they could negotiate that exam, then move on to their specialist training. There was also another issue, which is that many trainees want to acquire some academic training, some research background, but for that to be achieved, normally that would require the trainee to take time out of their surgical training away from clinical practice to undertake a period of research, which could be as long as 3 years for a PhD. And of course, for those who wanted to better themselves by getting these additional academic qualifications, the issue was that not many of them would pursue an academic career in surgery, although it's recognized that these individuals needed to understand the evidence-based medical practice to ensure quality delivery of surgical healthcare to their patients. We recognize that the problem of the trainee being unsupported in the exam could be addressed by providing a parallel educational program. We, in 2007, launched an online education program, a master's program, which was based on the curriculum for the membership exam, but also delivered a fair amount of this academic training without the need for the trainee to take time out of their surgical training. I'm going to talk a little bit about the Masters in Surgical Sciences, because that was the one which was most readily taken up by Malawian surgical trainees. But a year or so after we launched that Masters in Surgical Sciences, we responded to demands for a similar, more advanced online program that related to the exit fellowship exam and ultimately set up some online education programs related to that. The online program is a 3-year program, which is about the knowledge base in those areas that are clearly relevant to surgical training and also to the assessment and care of the surgical patient. And these first 2 years were delivered through a series of case scenarios with the students being supported on discussion boards and then an end-of-year examination. But in the 3rd year, once they had negotiated these first 2 years, would undertake a project, an independent research program with a supervisor and being supported by our online team, so that after 3 years of study and research, they could come out with a master's degree. Clearly, the intention of this program was also to help the training surgeon in the United Kingdom present themselves for their professional exam and have a better prospect of getting past that hurdle. So the rationale of this online program was very much to support the surgical trainee, and for the MSc in Surgical Sciences, it was in the early years of surgical training. This was to help the trainee acquire the understanding of the applied basic surgical sciences, to consolidate their knowledge base for their professional exam, and to support their professional development. And this was set up not to replace their workplace training, but to complement that training. And obviously, for those trainees working in challenging environments, it was also to perhaps address some of the deficiencies, the inability of the local training program to perhaps cover all of the educational bases. We know that these programs were an opportunity for ambitious trainees to acquire additional qualifications which would enhance their curriculum vitae, their portfolio, promote their career development, but importantly, provide the trainee with essential academic tools to support lifelong learning. It was also an opportunity for prospective academic surgeons to acquire a qualification which identified their career intention. And we know that for some of those who enrolled in our programs, it provided them with a base to go on and undertake a full-time career as a clinical academic. And of course, as you'll see, the beauty of these online education programs, because they do not require the presence of the student to be based in Edinburgh, is that this delivers equity of access to training surgeons no matter where they're based. So these programs were delivered on a dedicated virtual learning environment, which meant that at the click of a mouse, the trainee could identify where they were in the program. They could access appropriate resources and could be taken through the curriculum without their having to reference a paper textbook. All of the resource was there online, available at the click of a mouse. The programs were successful because they were contextual. Our intention initially was to try and support the student through the master's program in negotiating this membership exam. And when we looked at this a number of years ago, we identified that those of our students who were on our Edinburgh Surgery Online program or surgery qualification had a 20% better pass rate in their professional exam than those students who were not enrolled in our program. So it was fit for that specific purpose. But of course, because our programs were online and discussion boards which were creating this community were asynchronous, it meant that the students could log on from anywhere at any time and on any device. We encouraged collaboration between students and with the tutors who were looking after the groups of students on our virtual learning environment, as I say, trying to create this community. And of course, I wouldn't put forward any negative comments, but the feedback that we've had from students have been that the programs have been enjoyable, they've been stimulating, they've been innovative. The students have felt well supported. And I'm going to come back and talk about this very issue of training surgeons being able to remain in their own healthcare environment whilst bettering themselves. I don't think that we could have predicted the success of our programs when we launched them in 2007, but there's been an exponential increase in the number of students that have been recruited since we launched the programs in 2007. And indeed now we have a total of 8 master's online programs with currently some 550 training surgeons in over 70 countries enrolled on our programs at any one time. And since we started the programs 12 years ago, over 2,500 training surgeons have enrolled. So clearly the programs have been successful just in terms of enrollment. And the global outreach of these programs has been quite extraordinary. I don't think that we had necessarily anticipated that the programs would be delivered just quite as strongly as they have been internationally. And what I now want to do is just spend a couple of minutes telling you of our experience in Malawi. I'm sure some of this will be familiar to many of you. In 2004, when this particular study was published, it was noted that Malawi had one of the lowest doctor staffing levels in Southern Africa, with just over 2 per 100,000 population in 2010, compared to, say, Greece, where the number is 620. Malawi's got one of the world's lowest physician-to-patient ratios, and in 2013, that was estimated at 1 surgeon per million of the population. When we started our collaboration in Malawi, we had worked out that there were in fact only 15 qualified general surgeons for the population. And the reasons for that are many, but obviously one of the problems is that doctors who wish to pursue further training and do so overseas may fail to return and contribute to the shortage in healthcare workers. Well, our experience in delivering online education in Malawi has really been quite interesting. We will just acknowledge the fact that when we undertook our first support of Malawian surgeons in 2010, that was with the support of Johnson & Johnson Ethicon through an education grant. I know that Dennis Robson is very much involved with the Scottish Malawi Partnership. I think he's online as well, listening. So I'll take the opportunity of lauding Dennis and Johnson & Johnson for this initiative, because what it allowed us to do was to provide full scholarship funding for training surgeons in Malawi. And so since 2010, we've had about 2 or 3 surgeons every year supported and enrolled in our programs. And so since 2010, when we had our first student, we've now had a total of 30 training surgeons enroll on our programs. There are currently 2 in year 1, 3 in year 2, and 1 in year 3. But we've now graduated 18 of these training surgeons over the last 10 years. We've had 1 or 2 who've withdrawn, 1 because they no longer wish to pursue surgical training, 2 exited without an award, and 1 is actually on an interruption of study. We had 1 who left Malawi after year 1. She, in fact, relocated to South Africa. She continued in the training program without scholarship funding. And she has, as I continued without scholarship funding, but I know has now come back to Malawi. We've had 1 who's graduated with a certificate. So our success rate has actually been very good in supporting our Malawian training surgeons. And I also just point out that surgery is sometimes seen as being a male-dominated specialty, but 14 of the 30 students that we have supported have, in fact, been female. And of these 30 that we've put through the program, of those who've continued in a career in surgery, only 1 has left Malawi. So it's really helped the capacity building in Malawi. And here are just a couple of simple case studies. Lugano Kalangalero was our first graduate from the MSc in Surgical Sciences program. And when he came to Edinburgh to graduate in 2013, that was the first time that he had been out of Malawi. There was a little bit of press coverage in relation to this, but it was he who quoted that he'd been able to remain in Malawi to learn whilst continuing to treat those who needed him most. And Lugano is still working in Malawi at the present time. I indicated that I was in Malawi last October. We ran a capacity building retreat, and here's Wonabanda, again, one of our Johnson & Johnson scholars who graduated the year after Lugano. She used the program to help underpin her training in plastic surgery. She is now working as a plastic surgeon in Kambuzo Central Hospital in Lilongwe. And at the retreat that we had in October, we have connected her with like-minded graduates from our programs so that she can engage in research collaboration in burn care in the burns unit that she's running in Lilongwe. And Vanessa Sosa, also a Johnson & Johnson scholar, excuse me, she graduated in 2017. She is now enrolled in one of our more advanced programs as one of our own global scholars. And she, again, has been a great advocate for the programs. You know, the interaction with international trainees have been an eye-opener. And she, too, feels that this will have a huge role in strategic development of tackling disparities in global surgical care delivery. Johnson & Johnson are still supporting our programs. We have now also attracted additional funding from the Commonwealth Scholarship Commission. This year we'll have 5 scholarships from them. We've got some additional philanthropic funding. from private individuals that also are there to support training surgeons in low and middle income countries. And we have also now, with the College of Surgeons in Edinburgh, agreed to fund another 25 scholarships, again, to support trainees with full scholarship funding from low and middle income countries. So we think the programs have been pretty successful. That partly relates to the historic Edinburgh brand. Clearly, the global reach that we have through bursaries and fellowships has helped us extend into those parts of the world that the College of Surgeons perhaps were not traditionally involved with, but which the University of Edinburgh very much wished to engage. Our virtual learning environments are flexible, readily accessible. They fit with modern learning methods. The trainee engagement has been excellent. Clearly, the intention was to help to prepare trainees for their professional milestones. In the United Kingdom, that is for the membership and fellowship exams, but the professional milestones in other parts of the world are very, very similar. It clearly has increased experiential learning for the training surgeon. It's given them access to academic opportunity, and they have not had financial loss as a consequence of full-time postgraduate study. We've worked hard to contain the cost and the fees for these programs. Our tutors are very engaged with the programs. It's good for their own continuing professional development. And what we have really enjoyed in this last few years, particularly with our outreach to sub-Saharan Africa and Malawi, is this opportunity to assist with capacity building. So we think the online surgical education programs have helped to underpin the global reputation of Edinburgh medicine, and we have really very much enjoyed our engagement in sub-Saharan Africa and with the training surgeons in Malawi. So I'm happy to stop at that, and thank you very much for having the opportunity to speak this afternoon.
James, thank you very much indeed. Clearly a tremendous impact and sustainable achievement, particularly with the retention of the trained surgeons who've gone through the master's program remaining in Malawi. Just with the coronavirus COVID-19 section and time in mind, I'd propose that we hold questions for the end and move on to the second section. We're going to make your presentation available online afterwards, James, with your kind permission. So I hope you'll forgive me moving swiftly on to COVID-19 and taking some questions in the section at the end.
Not at all.
Thank you very much. Well, on COVID-19, the President of Malawi last week declared a state of disaster, closing schools, restricting movement and banning assemblies of more than 100 citizens, being advised to practice social distancing and to wash their hands frequently. Here in Scotland, we're in lockdown with the Chief Medical Officer, Dr. Catherine Calderwood, having advised at the beginning of the week that there may be limitations for a further 17 weeks. To hear a perspective on the situation in Malawi, we'll turn first to Dr. Tracy Morse, who's been based in Malawi since 2000 and is an environmental health practitioner and research fellow with the University of Strathclyde and known to many of you. But perhaps here, Tracy, and feel free to clarify, speaking in a personal capacity.
Hello, everyone. Yes, we're having some fun times. Malawi is now on, we're not on lockdown, we're on lock-in. So we are, the international flights in and out of Malawi commercial flights have suspended as of tomorrow. As you've said already, Stuart, the universities are now closed, the schools are closed. As of yesterday, Blantyre City also put out a number of notifications about street vending and nightclubs and things, trying to improve social distancing, which of course is an incredibly difficult thing to achieve in the urban settings, especially that we have here in Malawi. And it's incredibly difficult also for the economy as it is there, where a lot of people are reliant on street vending of produce and things as well for their income at household level. There's been a lot of mass media here on preventive measures. I think, as you already know, we don't actually have a confirmed case of COVID-19 here in Malawi as of yet. We've got, and Prof. Mapanda will talk much more eloquently about this. I think we have 3 testing centres now in country, here at MLW, where I'm at a meeting today, College of Medicine, and then in Lilongwe at Chisu. But we don't have any confirmed cases, but it's very limited testing that's going on at the moment. And there's been a lot of mass media, obviously, to try and improve people's awareness. As an environmental health officer, you know, apart from the obvious downsides of COVID, I'm absolutely delighted to see so many people washing their hands. It's what I've been trying to achieve for so many years, but I would rather it didn't come with, obviously, the worries and concerns that we have in Malawi if it does hit here. One of the main concerns, I think, are a lot of population are coming back from South Africa now as well on buses and by road, which is one of the reasons why the borders are being closed and carefully monitored very soon. But otherwise, life kind of is going on as normal here. We're going to work, carrying on. We don't have a working from home status yet or a complete lockdown. We even have some research programs still going on, which are very low risk and involve minimal contact with other people. As far as University of Malawi is concerned, we have a task force which has now been developed. All of the separate universities had developed different guidelines. We're now trying to consolidate those into one set of guidelines across the university. Obviously, the students have gone home, but the staff are still on campus at the moment. And working from there. Not being from a medical side, Prof. Mapanda will talk much more, I'm sure, about the medicine, but as you can imagine, I think the main concerns here are PPE for medical staff and emergencies. There's very little available locally, and even with money available, there's not really an ability to buy PPE that the medical staff will need. So people are looking into local solutions that they can develop. There are significant concerns about oxygen access as well and availability. And as I said, we already have we have diagnostics, but they're very limited at the moment. And I think really probably that's all I can add. We do see a lot of hand washing going on, which is fantastic at different institutions and buildings. People do seem to be taking it seriously. I've heard from our teams even in the rural areas that people are talking about it. They're talking about how they can prevent it, which is great to hear. So obviously some of the messages are getting out well on the radio and on television and through print media too. So hopefully that was useful.
Sorry, sorry.
I think I can add something.
Thank you, Vera.
Is it okay if I can just add from what Tracy has said?
Yes, please do.
Okay, I think after the declaration, I think a lot of people did not understand, because the key thing that is happening at the moment in the country is for us to get the message down to the level where every person, whether they went to school or they didn't go to school, understands in terms of the extent of the issue, how dangerous it is and all that, both at the global level, but also at that lower level. And I suppose since the declaration, that's what the Ministry of Health has been trying to do. And pretty much the message has been around prevention and wash your hands, like what Tracy is saying, wash your hands, maintain a social distance and whatever. But we know that if you go into markets, for example, if you go into ShopRite, these supermarkets, the social distancing is not really being observed, but at least people are a little bit conscious. If you go around town, you can see people wearing masks, and even though I think a lot of people don't don't even understand the issue of masks, but they're still wearing them. So at least we are winning on that front. But I think for me, what I wanted to talk about the most was what the government is doing, because I think pretty much everybody is blaming the government. The government is not doing much and all that. But I would like to say just a few things about what I know that the government has done with support from the World Health Organization and obviously CDC. They've set up 2 testing sites. Today I met with Dr. Poya, who was supposed to be part of the meeting. She was coming from supervising.
I'm online, Vera.
Oh, Dr. Poya is here. Yeah, so Dr. Poya can just explain. But I think for me, what I wanted to say was, while the population is thinking that the government is not doing much, actually the government is doing something. We may not know all that the government is doing, but I think we should be confident that the government is doing something. So probably Dr. Poya can give some information in terms of what is happening at the moment.
I'd also echo that, Vera. I think there's some people in government who are working extremely hard in very difficult circumstances.
Yeah, I can probably add in 1 or 2. I think after the presidential declaration, what the ministry has done is they have now come up with guidelines to guide people on what to do in each different situation. For example, now we have guidelines on what to do for congregations that want to meet and pray. There are guidelines on what to do when people are taking the public transportation. There are also guidelines on what to do when you are sick, and what, there's already a hotline people that can call to find information. But also, most of the border cities, for example, in Karonga, Mchinji, Mulanje, Mangochi, and Deta and Nchewu, they have placed in screening sites, including hand washing facilities for all these places. And I've also noticed in some markets, for example, here in Lilongwe, at the produce market, when you go into the market, you're forced to wash your hands. But since the market has so many gates, I won't know the other gates, but at least I saw 1 gate where hand washing was encouraged. And right now, government is busy training health workers on how to manage in case we have an active case, because most of the people in Malawi are gripped with fear, so they may come to the hospital with the symptoms that are not necessarily COVID. So currently the training is going on, but partners that work with government, like for example, my own institution, MSH, we are busy in the communities providing information, like what Vera has said, that most people may not understand exactly what you need to do. For example, I've noticed there's a lot of misuse of masks, because WHO has put in guidelines as to when you should use a mask, but sometimes people are using them unnecessarily. So I think that's what I can add for the time being. And of course, my own institution now is renovating the isolation site here at Kamzu Central, that if in the case we have an active case, there should be an isolation unit where patients can go. But in the other border towns, they are also holding sites where if we have suspected cases, they could be there. So for the time being, that's what I can say.
Dr. Poya, Vera, Tracy, thanks very much, all indeed. Turning to Dr. Antonia Ho in Glasgow, I believe you can advise us a little more on testing, Tony.
Forgot to unmute myself. You can hear me?
I just made that mistake a second ago too, yeah. Thank you, please go ahead.
Yeah, good afternoon. So I'm Tony Ho. I'm a clinical senior lecturer at Glasgow University and previously worked in Malawi and coordinated sentinel surveillance in Malawi. Just to add to what Vera mentioned, and Anne as well, is that yes, the Ministry of Health have been working very hard. I've been liaising with them actually since the end of last year to try and set up national influenza surveillance. And actually, as this outbreak unfolded, they have had support from the WHO. I think they have now set up testing at the Public Health Institute in the Longway, and the other two testing sites are the College of Medicine and Malawi Liverpool Wellcome Trust Clinical Research Programme, both based in Blantyre. I also have a colleague, Kayla Barnes, who is also works at the Centre for Virus Research, but is based in Blantyre. So she is today just to get an update on how testing is going. As Tracy earlier alluded, there is limited testing to date, but all three sites are now set up for testing. I think FIM has tested about 20 samples, MLW around 23 samples, and College of Medicine is also a small number of samples, and they have all returned negative, and they're hoping to increase the testing. One reassuring thing is that they don't seem to have seen an increase in the pneumonia cases that are being admitted to hospital so far. The issues in terms of testing is that they can't, particularly cold chain reagents and PPE are really key issues that are key problems, because the MLW had requested a number of cold chain reagents that basically didn't make it into the country before they closed the borders. So that's really an issue. And at the moment, I think both the College of Medicine and the Public Health Institute are not able to get all the assays that they want. So they're currently using a Chinese assay to test their samples at the moment. One other development before I finish is that I think they have received a donation of 20,000 rapid diagnostic tests that was donated by Alibaba, and that's being distributed by the Ministry of Health. And hopefully this RDT can be validated by any of the three labs. And I think really going forward with difficulties in getting reagents, I think, the focus should probably be on expansion of rapid diagnostic testing. That's all I have to say.
Tony, thanks very much. That's really, really useful and positive to hear that there are no.
Probably, Stuart, if I can just say something about expanding the testing size. This morning we are negotiating with Kamzo Central, the director, Dr. Ngoma, if their lab at Kamzo Central Hospital could also be a testing site, because when patients are moved back and forth, for example, here in Longwe, they have first of all to report to the district health office before their samples are taken to go to the national lab, and then they are sent back to Kamzo Central for screening with a specialist. So we are saying it is better that if the Kamzo Central Hospital lab was also validated as a testing site, and we are hoping that will improve soon. Thank you.
Thank you, Dr. Poya. May I check, Principal Mapando, are you with us from the College of Medicine, University of Malawi?
Yes, I am here.
Super, welcome.
Sure. So I will share something. If it's my turn to present, I thought maybe I can.
Please.
So deliberately, I've invited my team so that maybe people are aware and we are talking from facts. As a college, I set up a team that is made up of clinicians, public health specialists, and diagnostics as lab people. So with me, I have Dr. Puka, who's the chairman of that particular team. Maybe he can wave. Deliberately, I thought he could join me because he's sitting at the national level every week. So he has the latest information, and we are also chairing the Blantyre coordination team. So he's the co-chair. So I thought he could join me. I have also Tony Nyirenda here, who is in charge of the diagnostics. So the subcommittee on diagnostics on testing is the guy that is doing that. So I thought that there might be questions, maybe they might comment on, so that you can really get what is happening. Basically, my presentation, I'm hoping you have it there.
Yes, thank you. We can see the presentation. It's full screen at the moment on my screen, so we're not actually seeing you, but we can see your slides. Thanks.
I'll ask my technical person to do whatever he does, but whilst doing that, I can be talking. Basically, what we are saying, we don't have yet a confirmed case. And as already mentioned, we have very few testing capabilities. And as a college, we set up a team that is helping to the national response. And also at the moment, whilst the Ministry of Health at the central level, they are concentrating for central region and the north where we don't have any confirmatory test. On the Blantyre or southern region side, even to Mangochi, College of Medicine is providing leadership together with the DHOs that are here. And from the onset, I would want to say thank you for the support that we are receiving, both internal partners, because the testing capabilities, we had the infrastructure, but the consumables and others is through World Health Organization, DFID, that has supported. And also thank you to Scottish government. I know they have provided funding that will capacitate our laboratory further. So I thought I should talk about that. This is the latest from last evening, the report, but basically what is showing you, we are able to follow whoever is coming in into the country, both through the airport and also through the border, land borders, and they are being followed, and it can show you the numbers that are being followed up and the cumulative discharges, represented in the same way by seeing the numbers. And if you look at the bigger numbers, mostly they have come from South Africa, and we have been able to do the testing, the confirmatory, as indicated already, at the National Health Reference Lab in Lilongwe, here at College of Medicine proper, and also at MLW. This is what officially has been presented, and you can see that the MLW, though Antonio has said 23, I think the communication to the national level hasn't been done. So we'll follow up with that figure, because every day they are collating what we are receiving. But this is officially what has been done, and Tony can confirm that the results have come out negative. We are able to test not only for Blantyre, we were able to get from Mwanza, Mangochi, and Zomba, because we, in the southern region, we are the only ones that are doing. At what is happening nationally, you will see that screening is being done. And I think the things that Annie had talked about, and there are some things that are coming into effect from tomorrow. The private sector is coming in. So what we have done in the southern region is to work as College of Medicine, Queens, and Blantyre district office. When I say College of Medicine, it means they are affiliates like Wellcome Trust, John Hopkins, they are under COM, and others. We are working together. And what we want to do is to have a concerted effort, in a sense that all the public sectors, the public sector engagement should be a coordinated one rather than working with different people. What is also more important to our Malawian setting is how do we handle rumors, because social media misinformation is important. So there is already a way of doing that, and the capacity building for health workers. I know today, actually, before I came into this meeting, we were told that over 500 healthcare workers in Blantyre have been trained. We are wanting to upgrade the testing site, and I'll talk about that. John, every Thursday, they are meeting at the national level, where it's chaired by the Chief of Health Services, where they are discussing of what is happening and new knowledge. And as a college, we are inputting into that through our public health specialists and even the clinicians. Now, at a College of Medicine and Blantyre level, I'm happy to say that there is a coordinated effort, and the team is being led by the DHO, district health officer, and also John here. They are co-chairing that team, coordinating everything that is happening in Blantyre. But when we say coordinating Blantyre, it means it's also for the whole southern region. We have limited capacity for quarantine. I think what we were told, about 16 or so, but it can be extended to 40. And the ventilation capacity, I think MSH has bought 4 ventilators, but we still need quite a lot. At the College of Medicine, we've done the diagnostic, so I think Tony can talk about that, and the clinicians are working at Queen Elizabeth. Students, we send them home. We are trying to explore how we can deliver online. We think maybe if it comes to it, we can also use our infrastructure mostly for the healthcare workers like hostels and the private clinic to provide support to that. And as indicated, MLW, I know, which is our affiliate, they have got funding for testing and also the oxygen plant, which we hope we can have within a month if we have the logistics of bringing it from South Africa. So in a way, we need, as Malawi, the numbers are small, we need to test, and I thought maybe Tony can just talk in terms of the testing a little bit, and John will finalize the last bit of how, as Malawi, we can respond since he sits at the national level.
Just to emphasize the point that we need to build capacity in as far as testing is concerned. So far, we have tested very little, but what we need now is test more, test. So far, we don't have the rapid diagnostic test. In this case, I'm talking about the immunoassays. We don't have that in the country. Of course, for the reasons that these are a bit problematic at this time around, for the reason that the sensitivities and specificity of the tests that are there is not clear, but also some of them, their sensitivity and specificity is actually low. So the way to go so far has been molecular, and as you might be aware, this takes a bit of time. We're talking about a minimum of 6 hours, but it can actually be longer, considering that at times we have to actually batch the test itself. But the alternative for complementary tests is actually the gene expert. As a country, Ministry of Health, of course, has already made a decision to be able to buy, cartridges for the gene expert. As of now, we have, as a country, 114 gene expert machines across the country, meaning to say that if we are to scale up, the testing capacity, the way to go is to also make most of the gene experts. At the college, we have got 4 gene expert machines with up to 16 modulars, meaning to say that we can be able to learn at least 16 tests every other hour. The turnaround time for gene expert is less than 1 hour. So if we are to consider 1 day, then we can actually done 16 times 8. So that would actually make a significant impact in as far as testing capacities is concerned. In the meantime, we don't have them in stock, of course, for the reason that, as you might be aware, a gene expert technology for COVID has recently been approved by FDA, and that was just last week. So the decisions are really just being made now. This is an emergency, we actually need them, and if we could have at least 3,000, that would go a long way in really capacitating the laboratories so that we can be able to provide this. We think that this should be the way to go, considering that the turnaround time is less than 1 hour, and that is very important in as far as testing is concerned. So I'll let my colleague, John, to actually come in to add to what I've just said.
Yeah, so maybe I would sort of categorize my response into one, public health. So indeed, we have seen an upgrade in the way we are behaving, with lots of hand washing that has come in, and these are almost everywhere where we see buildings. But I think we need to complement that with additional approaches, because people can go past that gate, but once inside buildings, then perhaps we also need to consider that there would be contamination. So there's need to continue to support the industry and whosoever is working on this with new ways of risk assessment. We have upgraded, but we need to step up to ensure that there's there's enhanced behavior that supports that. There are other issues that as a nation we are working towards, that includes social distancing. There are challenges around that, but there's policies that have come in that are safeguarding that. What we need to ensure is that they're being adhered to from both urban and the rural setups. Policing for that will be quite a challenge, but I'm sure we'll step up in that direction. Then once that has failed, I think there's the actual cases, local transmission and so forth. I think in this regard, once we have cases, there's need of enhanced support to support mobile. So those that are in self-quarantine or quarantined in the houses and so forth, there's a need of a strong build-up of teams to go and support, screen those in the homes, and then also feedback mechanisms at what level really is somebody in their home, so that only those that need care can move from the homes. Clearly, this is a massive operation that needs supporting logistics and all others. And now we are faced with an equivocal environment whereby we are challenged, but for good reasons. Teams that were here to support us from elsewhere, a good proportion of clinicians, nurses have been evacuated. That means we have had an impact on our human resource as well. We have a pool of human resource that's lacking out there, either those that are newly retired, but those ones may be the ones that are at risk. So they may be actually affected more. So maybe calling them back may be a big question. The ministry is considering really to say, how about the young doctors and nurses that can come in quickly so that they can support to beef up the human resource. And once we have that, that means that from the human resource, we can support those that need mild care, moderate care, and then maybe leave the specialists to support those that need the 5% that needs critical care. That's the human resource. The infrastructure, we need space, we need equipment to support the moderate to severe cases. Our ventilation capacity is very limited, less than 20 ventilators at present. Some of those will be relocated to COVID resources, but obviously this is rather in already a limited capacity. So we need new upgrades in that area, ventilators, oxygen supply systems, concentrators, and all necessary elements that comes with life support. The other layer that I think will be very useful is assurance. We need to assure the service providers, the essential services. So those that are going to be in the front line of this war need to be assured. So we need to upgrade the safe so that these can also be assured and be saved. So that means in the care of the critical and moderate, we need somehow very clear pathways for those that are in the front line, those real soldiers that are in the front line of this war. How can they be supported? Amongst those is either location of areas where those that are working may not go home to reduce the risk of contamination of those in their own home, in their own households, knowing that health workers are at high risk. So these could be some of the quick areas that I can comment. The other thing that we are struggling with is surveillance. If there was a way of a digital tracking, this would be very useful to us to support the tracking, but also maybe building clusters of risk where this is and so forth. So those will be maybe the major areas I would comment at present. Thank you.
Thanks, Stuart.
Thank you very much indeed. May I suggest, with all of that richness of content, that we have the opportunity for questions. Does anybody have any points that they would like to put to Principal Mapando and his team, Tracy, Tony, Dr. Poya, Vera so far?
Hi there, Stuart. Kate James speaking.
Hi, Kate. Go ahead.
What we'd like to ask, so we've recently returned from Malawi, and to let people know, we were there originally supporting an emergency medicine and trauma project for Scottish Government, and therefore, sorry. Willen, I think you need to mute. Sorry. I'll try again. And therefore, we had the opportunity of meeting with the head of emergency medicine in 4 of the hospitals. And towards the end of our time 10 days ago, we were obviously having COVID conversations. And our question is really the support for those heads of the emergency medicine departments. 10 days ago, they felt totally unsupported. And I'm not going to hold back on saying that. And I just think that is really, really important. And I just want to make sure that that is happening now.
Yeah, so
is it possible, Stuart, to take a number of questions at one time so that maybe we can, if we need to respond?
Yes, sure, let's do that. Anyone with other questions? Just looking on the chat to see if there's any. Rachel Phillips, would you like to come in? Dr. Rachel Phillips.
Hello, can you hear me all right?
Yes, thank you. Go ahead.
I just wanted to ask about PPE getting and how that's going to be got around the country to all the rural district generals and health centre clinics, because we're struggling with that here in Scotland, and I'm just wondering what the plan would be in Malawi to do that.
Okay, Rachel, thanks. Anybody else?
Yes, it's Heather here.
Heather,
I have a comment. I'm actually in Argyll in the west of Scotland, and one of our local GPs has actually found a way of producing 3D printing face shields with minimal equipment. I wonder whether that would be something that might work in Malawi. I know that in the Polytechnic there's a very good innovation centre with 3D printers, and Tracy, you will know of it, and whether I can persuade this GP perhaps to share his programme for that. It's simply using acetate sheets but with a structure on the top and ties which are clearly available readily. Would that be of interest for me to try and pursue locally?
thank you, Heather. Shupo, would you like to come in? Shupo Kumwenda, I wonder if you can hear me. If not, and you're happy for me to voice your question.
Hello.
Yeah, go
Hello.
ahead.
Shupo Kumwenda, yes, from Ekwendene, Covenant Africa Youth Organization.
Hi, Shupo.
Hi, how are you?
Great, thanks. Go ahead.
I was thinking if the government and also other partners can work with the community-based organization, this can help, really can help for awareness. That was what I was thinking. Do you hear me?
Yes, thank you, Shupo. Yeah.
That was just my suggestion.
Thank you. So, Principal Mapanda, I wonder if you're happy to take these 4 points. So, with Shupo's question, Heather, wondering if the 3D printing of face masks would be a useful innovation. Dr. Rachel Phillips about PPE and where the support is for the heads of A&E departments.
So if I can start with the PPE, that one, yes, we know that it's a challenge, but I know the government is procuring. The logistics, I don't know when it's going to run, but what they have done is that every district health officer will be in charge of each district. And once they have received the consignment, they are going to share it to all the district health officers, and they are the ones that are going to be responsible for that. That's why it's very crucial that the coordination at a district, like what we have done in Blantyre, is important so that there is a shared platform where things can be shared and can be voiced out. Otherwise, working parallel to that, it will be difficult to have access to that if you are working not with the district health office. In terms of the, similarly, in terms of the emergency people, it's sad indeed that maybe they felt like that, but I know that every, like at the central hospitals, they are presenting themselves. And I know today, the Queen Elizabeth director, they are at Capitol Hill, because initially they felt left out and it was mostly the DHOs. But today they are trying to see how the central hospitals also can have a voice and also bring out their, what their need is. But even that central hospital has to work under the district health office. So like today in Blantyre, the team that I was talking about, we had a deputy director for the Queen Elizabeth, and we have a DHO, and we are saying all our requirements like a wish list is going to be one, together Queens and district hospital so that we can have a shared facility. And I know also that at Queen Elizabeth Central Hospital, they are having an input in our isolation center so that we can work on triaging and also how the whole process should be. On the 3D, maybe I can ask, and also community-based organization, I can ask John because he's sitting at the national level, and also maybe Tony.
Maybe Paul can actually, so just to mention that the College of Medicine, our department has got a 3D printer, but I'm not very sure of in terms of its capacity, how much it can actually be able to produce these face shields. So, so first of all, we are actually interested. I think it's something that we would really need here. But I'll let the poly guys also to comment in terms of their capacities, how many they can actually generate. But definitely we need that. So if you can share the necessary information to be able to produce this, that will really be great. Johnny?
Yeah. So in this regard, I think the major guiding principle is collaboration. So in the area of printing, we'll collaborate in whatever way with colleagues from the Polytechnic. Actually, at the meeting today, we already had agreed that they will also be joining us in the subsequent Branda DHO collaboration platform. So on the specific, now going to the CBO involvement, in Malawi, we have the community health sort of a structure that goes all the way to the CBOs, and out there they collaborate. The frontline workers or the extension workers are the so-called HSS, Health Surveillance Assistants, who are by WHO definition community health workers. These have already now being prepared with training, and then they'll be part and parcel. So the CBOs obviously are very important because we need to find ways of cascading the messages all the way to the communities. So the CBOs and all other community structures are part and parcel of at least the health education structure, but also intervention structure that will be there. Thank you.
Thank you. Just looking at the chat and some more questions coming in. So 3 or 4.
Can I? Sorry. Oh, sorry. Go ahead, Annie.
Stuart, I wanted to add into the issue of the distribution of the PPs. Because I'm aware that government is not working in isolation, it is working with a number of partners. So some of the monies that have come from other bilateral institutions have been, for example, given to UNICEF. And UNICEF is contracting Red Cross that are working on the grassroots so that when the PPs come, they are able to distribute them in a timely manner. In terms of the CBOs, I know that at each district level, there's an emergency committee where all the partners working in the district sit together, they have a plan, and everybody has a role to play. So my request is that CBOs that are in the district, please make yourselves known to the DHO and their teams, because then you can be part and parcel of the district plan. Thank you.
Thanks very much. Tracy, did you want to come in?
I was just going to say, I know that I put it in the chat as well. MLW did actually produce a couple of masks today, which I saw some nice photos of with the 3D printer. And I know the guys at the Poly are looking at that, and they're also interested in knowing anything about low-cost ventilators that they could help with trying to manufacture as well. So if anyone has connections on those kind of things, they'd be very welcome. There's been a number of different questions about posters and things that have come up on the chat, and the government have produced some really good leaflets, English and Chichewa, and posters. And I think most of us here have copies of those, but maybe that's something that we could send to you, Stuart, that you could consolidate for everyone to get in one central area. Because there's a number of different, rules, regulations, guidance now that's come out from government, as well as the kind of mass media leaflets and things that have come out as well. So it might be useful for people to be able to access that in one area. I know I can certainly send on the ones I have, and I'm sure the COM team have a number that I probably don't have as well. And there's some questions about TAs and things as well. So yeah, I mean, the local structures are being used to spread the message right down from central level all the way to village level. And as I said earlier, it's very clear, and certainly some of the communities in rural Blantyre and Chikwawa that we work in, that message is getting through, which is fantastic. And again, if people are working with organisations here, I know COM do, I know we do at the Polytechnic and Watershed as well, we have a number of different toolkits that focus on promoting hand washing with soap, using different behaviour change strategies and things. And if you want access to them, again, I'll send those on to you so that you can circulate them more widely.
Great, Tracy, thank you very much. We're happy to speak after this call and to circulate some information. We'll work with our sister organisation, the Malawi Scotland Partnership, as well to see what is best and most appropriate to do locally in Malawi. Questions also on whether there are currently restrictions for the number of visitors that can go into hospitals. Also whether there are any songs that have been produced to help spread important messages.
There is some specific guidance that's now come out on hospitals, which John probably knows a lot more of the details of than I would, and I know specific rules as well now on people attending the mortuary and things as well. And there are some hygiene songs out there, again, things that we can share both with Vera and us.
Great.
Yes, I was at Kamzu Central Hospital this morning, and they are indeed implementing the policy of one patient, one guardian. So that is already in place in some hospitals.
So on the northern region, at present for the PCR, we have no machine in the north. The FEM in Longo, the reference lab, is the one responsible in the meantime. But as you've my colleague indicated, we are also moving into Gene Expert, and these machines are also available in the north. So churches, at present, we're applying the 100 maximum aggregation rule. That's my understanding, that we were allowing up to a maximum of 100 based on the declaration by the president. But this again is being looked into as to at what point do we begin to continue to reduce on these numbers. And I think at present the current state is in line with the fact that we don't have an imported case, therefore also no locally known transmission as yet. And as this is reassured again from the fact that as you're aware, most of the epidemics are actually sensed by community health workers, medical assistants, or local hospitals. There's no known unusual pattern of pneumonias, clusters of pneumonias in any of the district hospitals or their subsequent levels in all the districts.
And at Queen Elizabeth, now they have implemented the one person, and even they are going to lock all the entrance. We're going to have only one entrance through which people are going to come in. And we are working with them. We are working in terms of making sure that the hospital, the entrance, we are controlling that. There is a question on small donors. Yes, as Adrisa can talk for the Southern region, because we have brought everything together. We are going to have like work packages in terms of where people can take in to say on this list. So we could provide that after the vetting, because we are finalizing it by tomorrow. We will be able to offer for people who would want to be involved to be involved at a particular level. In terms of funerals, yes, I think they have already started in terms of the restrictions. They have provided policies on how it's going to be. And as Tracy has said, in Blantyre, that has been affected by even the mayor of the city.
Thank you very much indeed. That's all been extremely comprehensive. We will get some of the guidance material together and signpost to it, together with our friends and sister organisation in the Malawi-Scotland Partnership. I'd like to turn now to Mick and Kate James, who asked the first question there, from fighting poverty in Zambia, but just returned, as they say, from 6 weeks in Malawi. Mick and Kate.
Thank you very much, Stuart, and kind of welcome Lydia and Shupo and a whole bunch of other people that I've seen in the last few weeks. Good to see you online. I guess kind of just want to pick up on what Professor Mapando said, and I don't want to speak for very long. You know, when we talk to the frontline staff, certainly they, you know, they had a real sense of unease around the mantra of testing, 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 if there was no capability to put anybody anywhere. So at the time we were talking to them, their access to useful isolation units within the hospital infrastructure was very minimal. Infrastructure was one thing, but they were also significantly lacking in any staffing. So to staff an isolation unit 24/7 and to keep those staff separate from the rest of the hospital is a significant challenge for those clinicians at the front line. And they were pretty clear with us that at that point in time, there was almost no capability to deal with that. Good to see Lydia here on the chat, and I guess kind of one of the things, the tactics that we suggested was that they maybe went to the colleges that have had recently qualified nurses and sought to try and bring those nurses in to deal with that capacity issue that's bound to happen if you've got significant numbers of people having to move into isolation. I think on the other side of that coin is testing is all well and good, but you need to think about the maintenance as well. And Professor Mipanda, I'll send you the details for a maintenance engineer in Blantyre who's got significant experience of dealing with those the machines that you're talking about, and I'm sure that he would be willing to help. He's already been installing machines for the Wellcome Foundation and fixing faults that they've already found within that machine infrastructure as well. So I'll send you his details too. Really useful to hear again from Professor Mapando's team talk about QE, and they've got a single entry point into the hospital, and that's really kind of vital. I guess kind of you're fortunate compared to your peers in the other central hospitals, and in particular KCH, where it's a really confused entry system at the current time, and even basic signage to sign people between the OPDs or to the ETCs is lacking really within that hospital infrastructure. So again, just to kind of reiterate, any support, even just for simple signage to say, if you've got a cough and you've got a high temperature, please go this way. And again, really pleased to hear that there's been some useful steps taken to reduce the numbers of guardians that are coming, because again, for the wider audience here, useful to understand that in the Malawian culture, it's really common for people to turn up with multiple support people with them, not least of which because often they're required to be fed within the ward infrastructure. And obviously in a COVID-19 situation, that's just going to spread the disease. So I don't want to say any more. I mean, maybe, I don't know, Lydia, have you got something you might want to say? You've got loads of nurses I know who've recently qualified, and and I guess you might have a view on that, but I don't want to put you on the spot.
Hi, Mickey. Thank you for recognizing us from Ikwendeni. Yeah, we are happy. It's true, most of the times we have forgotten the training institutions when it comes to issues like this, but currently we have like a lot of graduates who are out there staying without anything, and if indeed there is need to beef up the human resource, I would really agree with you, Mickey, that they are of use as of now, and they can be taken to the hospitals, get trained, and then they can be part of the frontliners as in responding to the epidemic. So I feel like it's really important that in Malawi, and the government as a whole should look into that area, that what do we have at hand, like the graduate nurses were just saying, so we can really utilize them. And even I just wanted to add on to say we have taken a number of measures. Yes, as a country, we have closed down schools, people are in their homes, but now the issue is closing down schools is just not enough. We have to get back to those people and sensitize them on how best they would prevent the disease, because we have actually called everyone back home and we have increased the number of people within the community. Because if 500 students were in various schools, now they are called back to their communities, there is indeed a high risk of overcrowding and then increasing the risk of transmission. Now the issue will be the stay home. The stay home, we have to reinforce the stay home so that people should indeed know that it's not just coming back from school, but also implementing those simple issues that will not require us a lot of money of treating, but encouraging them to stay at home. And also sensitization, community sensitization on the hand washing and the sanitation in their homes and the markets. It's really important. So here as Tafika, Tafika is an organization based in Ikwendeni, and we have already started working on that, because we had an orientation of the headmasters and community leaders, which we conducted just a week before. We thought those are key people who can take the message back to their communities, and they can be part of the frontliners fighting the epidemic. And then when we have also arranged to take the message to the communities, we have simple mechanisms like using the public address system, which would reach out in voice to those people who are in their homes, not actually gathering people, but it will reach out to many communities. As we pass by in the road, people will be able to hear about the COVID-19 messages without making them gather in one place. And we're just sensitizing also those leaders where we conducted the orientation, that nowadays we need to limit the gathering in funnels. Let people understand that they need to be limited. We can give room to those who are grieved, and maybe just a few who can support in conducting the ceremony. So we are doing all what it takes to sensitize the community as an organization, and we have taken further steps that we have a planned community awareness campaign from next week, Monday up to Friday, which will be very intense, as we'll be going into all the communities around Ikwendeni and all the areas that we are partnered with. So that's why maybe Shuko came in to say how are the CBOs linked into this. So I appreciate what the ministry is doing, and we have known that now we need to link up with the Northern Region, like the DHO's office, the District Health Office, which will take up that initiative. We'll go there and introduce ourselves, what we are and what we are doing, so that we can work hand in hand on preventing this pandemic. So thank you, Mickey. We are there, we are doing the job, yeah.
Thank you very much, Lydia, for telling us about the work that you're doing on community awareness raising with Tafika. And Mick, thank you for your contribution. Some online reactions to that. Rachel Phillips says, I agree with Mick, unlike HIV, there's no treatment, so why test on the community if the need is to focus on prevention? And then oxygen treatment, question mark. At the moment, Scotland only testing on admission to hospital. Heather QB, Mick's comment about the value of testing if no capacity for isolation or treatment. In the short term, it might be the reassurance of negatives to ensure there's not further capacity reduction of healthcare staff as here in the UK. Also, not all positives will need treatment, so ensuring they're isolated is important. I'm conscious of time. Dr. Qasim Ahmed, Health Advisor for DFID Malawi, has been waiting very patiently, based in Ethiopia. Apologies for the delay to everybody with us running over a little bit, but so much material and valuable contribution here. Dr. Mohammed, are you hearing us okay and with us?
Yeah, I'm hearing really full comments and information. I don't see DFID working. UNICEF procuring its supplies, which is about USD. We anticipate challenge, obviously, but yeah, sorry that, but do this quickly. 1.8 million pounds.
I'm afraid I don't think that's working audibility wise. With much regret, Dr. Mohammed, we're going to need to stop there and try again, perhaps connecting.
Testing is important. Our biggest issue, which is
so Dr. Ahmed, again with apologies, and we just can't hear, I'm afraid. So if you could try logging off and logging back in again, and instead, Dr. Poya, I wonder whether you have further contribution or whether you've made the points that you'd like to make. Dr. Poya, I wonder if you're still with us. So then, Joanna Keating, Head of International Development at the Scottish Government, I wonder if you would be happy to join and make your presentation, please.
Yeah, thanks very much. Stuart, can you hear me okay?
Yes, thank you.
Yeah. I don't think a huge amount to say at the moment. I think that what we have been doing is obviously looking within the Scottish Government in terms of the organisations that we currently fund. I suppose in terms of this kind of wider conversation with civil society and others in Malawi, I suppose the key points from us, of course, as we all know, everybody now should be following FCO travel guidance, so that's in place. I suppose that's point number one, central point. For those in Malawi, of course, there'll be the instructions that Vera and others have referred to coming from the government of Malawi itself. In terms of our own programme, we're considering at the moment how much, I suppose, unallocated or unspent funds we may be projecting. That really depends on to what extent our existing project can continue. And that's across all three of the partner countries, Malawi, Zambia and Rwanda. So what we have done is write out last week to all of our projects. We've enclosed FAQs. There have been some questions to us around areas like salaries. So what we've done is write out just to confirm that we will continue to pay, and we will make that commitment to pay salaries for all Scottish Government funded projects until the end of June. So that will be a 3-month window where no matter what, we will continue to pay those salaries both in Scotland and in our partner countries. We are then at the stage where we need to assess where we are at that point, what for all of our projects now to start that Corona impact assessment to see whether or not what's going to be the impact on the projects. What I would say is it's unlikely at this stage that we would run any kind of funding round for COVID. It's more likely that we'll contribute to the central source, but we are in that regard at the moment. So really, it's, I suppose at the moment what we are doing is meeting Scottish Government response internationally. We're thinking about areas like small grants, making sure that they get all of the messaging that we're putting out as well. And really just as this first wave of what we're doing is about sort of supporting, advising our existing commitments to our grant holders, and then obviously interest, hence our reason for joining this call today. I think it's best to hear what in civil society, and just making sure we keep in touch with our crew as well. But obviously the sort of SNP and mass membership will be wider than our own programme. As Pat has said earlier, we've already just earlier this week we've made just a small grant for COVID-19 test kits at the College of Medicine, and so we have confirmed that earlier this week. And I guess, I mean, that there is very much in recognition of the long-standing relationship that we have with the College of Medicine through our Global Goals Partnership Agreement. So that's really where we're at the moment. I should say, of course, in terms of the Scottish Government itself, in the way that all other governments are obviously looking inwardly, trying to work out what the response should be. There's a huge amount of work, as you would expect, going on within the Scottish Government itself. So we're normally a team of 7. We are, from the end of this week, we will be down to 4.5 of us. So we've got 2 have gone off to health department on loan, and then for myself, I'm working part-time in my normal job and part-time in an old area of work, helping out with emergency legislation. So we are helping with the effort right across Scottish Government, as well as you know, our area has been given that extra sort of, at least that retained staffing, which we are you know, we're grateful for, to try and keep the programme and make sure that the grants can all be paid as expected sort of within the next couple of months. So that's probably where we are at the moment.
Thank you, Joanna. There were some very slight breaks in the line there, but nothing like the trouble with the line from Ethiopia, where Dr. Mohammed was speaking from. So thank you for that contribution. Would anybody like to come in? I see actually Dr. Qasim Mohammed messaging to everyone. DFID's put £1.8 million implemented by UNICEF, supplies of 500k expected in weeks. Supplies include equipping 6 TU. We're worried about testing access. Sorry, my interpretation of that's probably pretty fundamentally poor, but we'll invite DFID to provide a kind of written summary to share with the forum afterwards. So sorry that we didn't manage to get through. Dr. Mohammed did mention that the line might be a bit shaky. Does anybody have any questions for Joanna at the Scottish Government about her presentation or the situation?
Stuart, could I make one comment? This is Paul Garside. I won't burden everybody with the video, both in terms of bandwidth and what you would see. So that it might be helpful. So Joanna talked about the testing, and of course some of that's linked to the labs that people are involved in at College of Medicine. It might be helpful for people both here in Scotland and in Malawi to look at the calls that are currently out on the Chief Scientist's Office website. So those are calls related to very short grants that can be applied for a whole range of things linked to what to do with testing now, what to do with outcomes later. And some of those things may also be applicable in Malawi, and what you might do, how you might stratify patients and so on. So it just might be worth people having a look at those things.
Thank you, Professor Paul Garside. I wonder, Professor Brian Ngwenya, you had some questions. I wonder if you'd like to put these.
So can everybody hear me?
Yes, thanks.
Yeah. So I'm Brian Ngwenya. I'm Malawian, but based at the University of Edinburgh. I do have friends that work in the medical field, so really interested in hearing some of their views in terms of how we can help. And I had a couple of questions. One was really about you know, the where things are going in terms of preparedness, particularly looking at, so if we look at examples in Iran, for example, people are building shelters where most of the patients are housed because the hospitals can't cope. And I just wondered whether that's something that's been considered. So that's probably more for the College of Medicine group that provided some information about the initiatives going on.
Thank you, Brian. Principal Mapando, I wonder if you're still with us for that one.
Yes, we're still here. So we were discussing actually that one today, and the tents are being considered, mostly the tents for isolation and for triaging. We are also looking at schools because the schools have been, students are away, and that's both at secondary school and even like the university. So as I said in my presentation, like in our case at the college, we have considered that when time comes, if it's really going there, we have hostels that maybe the healthcare workers as a priority, where they can be isolated because we have, like, for example, a hostel that is self-contained, each one of them. So if it comes meeting the requirements, maybe that will be the extent that we can think of. We are also thinking of bigger tents that people can buy and maybe put them on the grounds. But the only challenge with the tents, it requires beds, it requires other amenities. Whilst if you're using a hostel or a school, you already have bathrooms and other things. But yes, that has been considered.
Thanks very much for that. The other question I think I posted on the chat actually was about communication, and one of the issues I think that was addressed about community communication was the issue that you're having to have people that are going in the villages or send, you know, or through radio and stuff like that. You can't help wondering that the telephone, mobile phones have really penetrated the rural communities in Malawi. And I just wondered whether it would be possible to engage the telecoms firms by way of their almost small donations to actually send SMS to the public. But obviously that would be government messages that go through, but engaging the telecoms companies.
So the both major suppliers of that service, Airtel and TNM, are donating either opportunity for direct message blasting, what's called IVR interactive approaches. Some of those have been done by the ICT Association of Malawi, whereby there's interactive message. You can ask frequently asked questions, where can you get a service, and so forth. There is toll-free lines that are being used as well in that regard. And I think Airtel at least is also offering website possibilities, or whatever they call bandwidth for hosting website. So the industry in that regard, as a telecommunication industry, is participating in the national response.
Okay, thank you. I think that's all for now. I really appreciate those answers.
Thanks so much. Anybody, any other questions or comments? Paul, I see that Paul Garside, I see you've posted an NHS Scotland COVID website URL.
Yeah, so that's where you'll find the links to the funding, and it's not only about applying for the funding, but if you look at the different areas for funding, so some of the funding is about stratifying patients, but some of it is also to think programs to look at how to help people deal with isolation, to deal with the illness, to deal lots of different ideas about the kinds of things that the Scottish government is looking for ideas and help with, and I think some of those things may be relevant to colleagues in Malawi should they wish to have a look.
Thank you for the website. We'll make best use of that resource. But I also wanted to highlight the importance of testing at whatever level you are. The biggest challenge we have at present is we are using the PCR, and it's sort of a slow turnaround time. But if we had the gene expert or the rapid test response, that would be still useful. Let's remember that about 80% of, at any point, whether you have 100 cases, 10 cases, at the time you have 10 cases, 8 cases can walk around and spread the disease. If we knew who these are, irrespective of the two, how we're taking care of the two, we could contain the 8 by self-quarantine, or actually at this point, isolation. I think that is extremely important. So if we had the opportunity to do the massive testing, I think I'm talking here not as government or anything, but as a public health officer, seeing the importance of testing and testing and testing. 80% at each time point would be isolated, right? That alone is a major contribution towards containment, reducing further spread. And that allows the healthcare to have time to prepare, to respond, to adjust the response level at which they are. Thank you.
I wonder if I could come in, Stuart. It's Heather here.
Please do, Heather.
There's been a lot of work being done in NHS Lothian's lab on respiratory viruses, and I will, in particular in COVID-19, including additional testing. And actually, interestingly, it has used some of the staff who've been part of our HPV network, which of course uses GeneXpert. So I think it would be very useful to have a discussion with some of the other tests that they've been trying, and also how they might relate to what's being developed within COM, and to use the expertise that there is here in Edinburgh. I can send both some URLs in a minute relating to some of the talks that were given in an open COVID-19 workshop just the other day. And there's a very good technical one from Dr. Kate Templeton, which I would recommend to anyone who's interested in COM in relation to the testing. So I will pass that on if I can work out how to do it just now or after the meeting through SMP.
Great, Heather, thank you. We're obviously very happy to share that information with everybody on the forum, on the website. Anybody else like to ask a question or make a comment?
Stuart, can I just make a quick comment?
Please do.
I just want to echo John at the College of Medicine in terms of testing. I think it's really, really important. Working as a clinician in the UK, you know, the quick turnaround time makes a huge difference in terms of infection control measures. This is particularly challenging in hospitals, in all healthcare settings in Malawi. So I think definitely prioritizing rapid testing, either by GeneXpert, which is a great option, but probably quite costly, or really investing in rapid diagnostic tests once we have a sensitive test. There are a lot of them floating around, but I don't know how many of them have been validated, and there have been some data suggesting that some of them really suffer from poor sensitivity, particularly early in illness. Definitely, I think rapid diagnostic tests would be really useful. One other thing to add is that we, at the Centre for Virus Research where I work, we are really working on rapid next generation sequencing using nanopore to really track the spread of the virus in the United Kingdom. And we'll be happy to support the College of Medicine to try and get that set up, just to give us more information as to whether this is community transmission or really travel related transmission. If they need any help, we'll be happy to support that.
Thank you very much, Tony. There was a question online. Is there a need for subcontracting plumbing companies to install emergency sanitary ware? Local plumbing companies has been added from Rachel. A user has also contributed. I understand that Airtel has already free rated data for the COVID-1 site. I've previously seen a suggestion to use the better hotels. They have low occupancy currently and all have en suite. Okay,
Stuart,
well,
can I?
Yeah. Who's that? Come in.
Willan.
Willan, please.
Yeah, I just wanted to say that dissemination of information in Malawi, more especially in local areas, it has not been done as it is supposed to be done. I have visited 3 villages recently, and one was today, whereby I was asking people what they know about this virus. And to my surprise, I find that many people in the villages, they just hear of the virus, but then they don't have much information on the preventive measures. So I would like to ask the government officials if they are with us around, and those who are working in at the departments, that we need to quicken up the spread of information as much as we can. Not all Malawians are on social media. Most of us, we talk, but we talk in social media, or WhatsApp, Facebook, and radio. But there are some people in the villages such that they don't have even radio, they cannot have such kind of information. So as Malawians, I think I would like to encourage every one of us in this forum to take this message seriously, that in rural areas, people do not have much of information on what can be done. I would like to concur with what Lydia said that we have really sent young people or students into their respective homes, but then they don't have much of information of what can be done for them to prevent getting contacted with this deadly disease. So as Malawians, I think every one of us, our friends from COM, our friends from hospital departments, health departments, we need to take this information seriously. We need to disseminate information to rural areas as fast as we can before things get out of our hands. Thank you.
Well, then, thank you very much for that important point about dissemination of information and making sure that the messages are really getting out there. Professor Heather Kuby also posted that link to the work from Dr. Kate Templeton. Everybody, thank you so very much. I'd like to turn now to our Chief Executive, David Hope-Jones, to summarise the key points and to identify some actions going forward. David.
Brilliant. Thank you very much, Stuart and colleagues, for setting up what I think has been a really useful discussion. I think the technology's worked well. I think we were up to 48 members at one point, with some fantastic contributors from both Malawi and Scotland, including the Scottish diaspora in Malawi and the Malawian diaspora in Scotland. In setting up this meeting, we were keen to strike a balance between the original agenda and obviously COVID, which has overtaken events when we originally set it. So my thanks first to Professor James Garden of Edinburgh Surgery Online for giving the excellent presentation with which we started. And I'm keen to join others in congratulating Professor Garden in the success that he and his team have enjoyed. We will share his presentation in full online. I want to take a few minutes to briefly summarize some of the key points from the COVID discussion, to set out from the Scotland-Malawi Partnership's perspective our priorities and principles going forward, and then some really practical next steps as well. This will only take sort of 4 or 5 minutes in total. So thank you again to all the contributions, especially those from Malawi. I do apologize again to Dr. Mohammed of DFID Malawi, who did agree to join at short notice, but obviously technology didn't allow for his verbal contribution, but we do recognise DFID's £1.8 million commitment already to fighting COVID in Malawi. And what we'll do is work with colleagues in DFID Malawi to share some of that written update. I think very important in summarising discussions to emphasise the point there are still no confirmed cases of COVID-19 in Malawi, and we must always be clear about that. I think listening particularly to the Malawian contributors, we've heard many successes despite a resource poor context in Malawi. The government has taken swift and clear action in closing schools, universities and gatherings of more than 100 people. There are 3 testing centres, as we've heard, that have been set up. There has been clear government advice and use of mass media to get that messaging out. A great many institutions have been proactive in setting up, for example, hand washing institutions outside sites or at which people gather. There has been a laudable degree of coordination, particularly from College of Medicine and the Ministry of Health. And there are good levels of awareness, seemingly, but I will come back to that. And that there are no unusual levels of pneumonia being reported at the moment. We also heard of donations of 20,000 rapid diagnostic kits, and also a donation from the Scottish Government already to COVID tests in the government of Malawi. We also heard a great many challenges. Let me summarise a few of those. There is, of course, a need to increase capacity of testing. Social distancing in urban, rural and remote areas as well is a challenge. The quantities of PPE, personal protective equipment, and their distribution, getting the reagents, the limited capacity in country to quarantine, the isolation units and their staffing, very few ventilators. If you read the news here, the criticism that UK government are getting for their level of ventilators and PPE, of course, it's a very different context than Malawi with less than 20, I think we heard. A challenge as well, support for the A&E heads, and Will and Alan's point about actually poor knowledge at the village level. So some really useful information there. Key priorities we've heard are HR infrastructure, awareness, surveillance, CBO engagement and testing. We heard many ideas that we'll look to follow up on. Heather Kubi's idea about the 3D printing, and we can look to share that information. Tracy's points about sharing the resources and posters. Paul's points about looking at not just calls that we could potentially apply to as a community, but also learning that we could share from the UK to the Malawian context. And finally, Heather's point about sharing between NHS Lothian and the College of Medicine. Each of these points we will follow up on. Friends, I'm keen to set out what I see as 5 key priorities and principles of how we'll follow up from this discussion. Firstly, we will look to disseminate information. We want to create a space for sharing experience, information and resources. We want to support coordination and collaboration between our members. We want to give good information to our members about how they can support their partners and friends in Malawi. But crucially as well, we want to be clear that Scotland is absolutely committed to the principle of do no harm. We don't want any Scotland-Malawi collaborations to be working against what Malawi is doing in this space. And we want to ensure that all of our members know about the restrictions, including on movement in Malawi. And we certainly don't want to be taking critical personnel in Malawi away from their vital day-to-day work for discussions. And so it's with an eye to that final point that I really want to make sure that we've captured maximum value from the 90 minutes that we've had today talking about COVID. What I want to do in very practical terms is to be able to create a space for continued open sharing. So after this, we will send across a SurveyMonkey link. I just want to add in another couple of questions, so colleagues don't send it out just yet, about next steps and how people can opt in if they want. I want to suggest that we create a WhatsApp group for those who wish to be able to share rapid updates, and we will have protocol on the use of that WhatsApp so it doesn't overload people's phones but provides useful and timely updates. I also in that survey want to take views on when it's useful to have a next meeting. Ordinarily our health forum will probably meet again early autumn. The reality is it is a uniquely difficult and dynamic situation that we're facing, and I think it would be useful to propose another meeting digitally like this in the 2 to 3 week time scale. But again, critically, we don't want to take senior personnel on the ground on Malawi unnecessarily away from their day-to-day jobs. So we'll be led primarily by our friends in Malawi in that regard. We'll set up a webpage devoted particularly, specifically to COVID in Malawi, in which we will look to curate the key details from the open discussions today and going forwards. to our members and the general public a clear sense of what's happening in Malawi and a clear message about how people of Scotland can help in that regard. And I reserve the right, if I may, to myself and colleagues approach a few of the people that have been on the call today to invite them to potentially volunteer to help doing that curating job to make sure we get the right messages at the right time to the right people. So as I say, we will follow up by email to everyone on this call with a SurveyMonkey link. It'll take your feedback on how useful this meeting was, but critically, it'll invite you to be able to opt in as you wish to those various follow-ups from here, including another meeting continuing to use Zoom. Also, by the end of this week, the Scotland-Malawi Partnership will have published its full COVID response strategy and risk register, which will obviously include the outcomes from this meeting. I hope it's been useful for everyone. My thanks again to all contributors. My apologies to those who have battled with technology, particularly DFID Malawi, and thanks to my colleagues. And Stuart, if I could pass back to you just to finish off. Thank you.
David, thanks very much. And thank you to all of our speakers and to you participants. As we said, we'll share the slides. A recording of this online forum will be available on the past events page of the Scotland-Malawi Partnership website. We'll signpost to that on social media. As David says, we'll share a feedback forum to invite you to steer us and lead us. I'd like to finish by drawing attention to our slide here with the offer of really any support that you feel would be useful that the SNP can provide during the coronavirus times in Scotland and Malawi's preparedness, and the steps that we've been hearing are being put in place. Thank you to my colleagues Craig and Gemma for all of their technical support and help, and thank you very much again for taking part today. Thank you for now, and we'll sign off. Bye-bye.
Bye.
Thank you.
Bye from